Thanks for the opportunity to speak with you all today. It's really a privilege. I'm going to be talking about cognitive functioning generally within the context of cancer and cancer treatment. And the reason why I'm speaking more generally is because there's not a whole lot known regarding the cognitive profile specific to melanoma and specific to immunotherapies. But there is ongoing work in this area, which I'll touch on a little bit. So patients have been living much longer over recent decades in terms of all cancer patients. This is particularly true for patients with malignant melanoma with the advent of immunotherapies. Since these treatments are becoming more and more effective, there's a focus not only just on prolonging survival, extending survival, but also the quality of that survival. And we're starting to see that in melanoma specifically. This is a recent clinical trial of combination immunotherapies, and they're including not only traditional clinical trial endpoints such as disease control, overall survival, progression-free survival, but they're also including as secondary endpoints quality of life. So it's not just about can this drug extend survival maximally, it's which drug, which combination of drugs can extend survival and preserve quality of life now. And a big aspect of quality of life for most patients is their cognitive functioning. In a broad survey of cancer survivors from the Livestrong Foundation, one of the top reported impacts on quality of life is cognitive functioning. They describe it as concentration, so attention, focus, and the ability to think clearly and focus, concentrate. 55% experience difficulties in concentration, yet very few are receiving treatment. 83% did not receive care for these issues. So it's an important area of consideration in patients. It's an underserved area. So what does cognitive impairment look like in the context of cancer and cancer therapy? So these are some quotes from some of my patients. I papered my house with Post-it notes reminding me where things were, what time my appointments were, when my friends' birthdays were. So this kind of describes short-term memory difficulties. Some of that forgetfulness, difficulty remembering details, and so forth. I suppose I feel now as if I'm coming out of a mist. I've been in some sort of mental fog for a while, coming out and clearing for a bit, then going into another patch. So this is also commonly described. The term chemo fog or chemo brain is often used, and that's really just because some of the clarity of thinking, there might be some fogginess, some cognitive malaise that patients experience, and this can fluctuate over time. It may worsen with each subsequent cycle of treatment. It may get better after treatment is over, but we really don't know who's at risk of these more prolonged difficulties at this point. And that leads to the last question, which we get all the time, which is how long can I expect these issues to persist? I'm 7 months out of 8 rounds of chemo and radiation, and I still have trouble. And that's an area of research that we're looking at right now. We really want to identify who are the patients at risk of these cognitive impairments, and what can we do to, one, prevent them, and two, to ameliorate them, lessen them after they do exist. So these data really come from studies of patients with breast cancer. And that's where most of the literature on cognitive impairments in cancer comes from. And up to 80% of patients with breast cancer report some cognitive impairment at some point in the disease course. That can happen just from cancer alone. So systemic inflammation from the cancer, release of cytokines, those can get into the brain, cause inflammation and cognitive issues. Chemotherapy can also cause similar issues. Radiation therapy can also cause inflammation and cognitive issues. So it's multifactorial in these different forms of cancer treatment. But what we notice is that regardless of the form of treatment, the type of cognitive impairments typically surround memory impairment, so difficulties with the short-term memory, difficulty with remembering details, new learning, not that kind of stuff from the past, that's fine. Processing speed, the efficiency with which we think, seem a little bit slowed down, not as quite as sharp as we used to feel, and problems with executive functioning. So working memory, the ability to multitask, to problem solve, to organize your thinking. Typically, in terms of chemotherapy, the problems that we see are generally mild in nature. But there is a subset that are more severely affected. And many patients will recover following cessation of treatment. When treatment's over, they'll kind of bounce back. Some might not get quite back to their baseline, but typically there's an improvement period. Now, there's also a subset of patients that will have persistent deficits, and some will even develop deficits later on in life. So chemotherapy tends to accelerate the aging process in the brain and make us a little bit vulnerable to the normal aging process. So patients who have a history of treatment in cancer may have an accelerated aging process, which they'll experience down the road. Again, we're trying to identify who these patients are, who's at risk, and to prevent this at this point. So for a long time, it was thought that chemo brain, cognitive impairment in the context of cancer was related to things like fatigue, distress, psychiatric concerns like anxiety, depression. And largely this was related to the fact that when we take a look at the brain of a healthy individual looks just like the brain of somebody who had cancer or cancer treatment. And that's using standard structural MRIs that you get when you go to your radiologist. Now, we've done some research using more advanced techniques. These scans aren't available clinically yet, but we use functional magnetic resonance imaging. And what we've seen is that there are indeed changes in the brain. So the brain of individuals with cancer, the brain of individuals with chemotherapy treatment is different than that of healthy controls. And we see changes in the gray matter density. Those are kind of like the central processing units, the computers that are all throughout the cortex of the brain. And those are less dense, so they're not working as efficiently. We see changes in the white matter. The white matter are the connections deep within the brain. They connect the CPUs to each other. And those are kind of like the Ethernet cables of the brain. And those white matter cables have less integrity. So the computers aren't working in sync as well. They're not connected just as well. And this is an interesting study where there's twins, and one twin had breast cancer and was treated with chemotherapy. The other twin did not. And they were given a task of working memory. It's a task where they have to use attention, remember things from the past that were just presented to them, and make decisions based on that information. So kind of holding information in your mind. And what we see is the chemotherapy patient is on the top. And you see a lot more activation in these conditions in the patient with chemotherapy. Now, interestingly, the two individuals performed the tasks identically. They didn't have any problems in their performances. Yet we're seeing this increased activation in the patient with chemotherapy. So what that describes is that it's taking more effort. It's taking more brain activation to get the same result. And that's what we often hear described by our patients is, yeah, I'm still able to get through my day. I'm still able to do the tasks that I need to. It's just a lot more difficult for me. I tire out a lot more quickly. And then using a functional connectivity approach, we see that there's disconnection between the brain regions. There's more disorganization, which is also what we hear described. And this has been related to objective performances on cognitive testing. So it's not just breast cancer. We see the same thing in patients with ovarian cancer, testicular cancer, colorectal carcinoma, prostate cancer. And there's ongoing work here at MD Anderson, spearheaded by Dr. Jeffrey Wafel, looking at melanoma, specifically the effects of immunotherapies on cognitive impairment. So we eagerly await those data. It's also not just chemotherapy. CAR T-cell therapies, immunotherapies can have cognitive side effects. The profile isn't well described yet, but again, that's an area that we're working on. And then radiation can have an impact on cognitive functioning as well. So patients with melanoma at risk of brain metastases, treatments can be gamma knife, whole brain radiation, and that can have a profound impact on cognitive functioning. So what can we do to maximize cognitive functioning? Well, work with your medical team, get a workup with your nursing staff, your oncologist, try to work up determine if there are any reversible contributors that we can treat. Blood tests for thyroid dysfunction, medication side effects, treat the depression, anxiety, stress, get a referral to psychiatry, treat any primary sleep disorders. Sleep apnea is common in patients that are cancer survivors, and fatigue. And treating those issues may in turn improve cognitive functioning. In some, that's not enough, and we'd recommend exercise. Exercise is the best thing for all of us. It's easier said than done, but getting about 150 minutes of moderate exercise per week. Brain healthy diet is key, and by brain healthy, we're typically referring to like a Mediterranean type diet, high fish diet, high in omega-3 fatty acids. Control your vascular risk factors, cholesterol, avoid smoking, moderate your alcohol intake. Manage your sleep hygiene, get good sleep, manage your stress. Importantly, stay sharp. So challenge yourself, learn a new language, learn to play an instrument, learn something new that's actually challenging and engaging. Don't sit on the routine tasks that are overlearned. The important thing is to move forward and try new tasks. Stay socially engaged. Patients with greater social activation tend to do better in terms of longevity. Their cognitive functioning stays more intact for longer periods of time. Moving forward, we're hoping to identify those patients and those treatments that have less cognitive side effects. And so we're incorporating cognitive functioning, objective tests of cognition in clinical trials to identify those treatments that are not only efficacious in terms of survival, but also have a less side effect profile in terms of cognitive functioning. We often get asked about cognitive training, like computerized cognitive training, like Lumosity, Brain HQ, Posit Science. The data is controversial there, but some patients do report decreased self-reported cognitive issues with those programs. Compensatory strategies like using a memory notebook, planner, setting reminders, timers, pill boxes, those things can be helpful. And then excitingly, we're developing some treatments, and it's at the preclinical stage right now, such as stem cell therapies in mouse models, where we really want to restore cognitive functioning and restore brain functioning. And things like drugs, stimulant medications, and neural stimulation are also in the pipeline. So in sum, cognitive dysfunction is very common. We encourage you to discuss these issues with your healthcare team. Request a neuropsychological evaluation. That way we can determine the extent of the cognitive impairment and develop an individualized treatment plan. And know that there are interventions available, so please speak up. And that's all I have for you.